Welcome. If you are watching this, it is because you are a nurse or a provider. Who cares? It also means you are probably a little bit terrified, and you should be. In this industry, we are constantly seeking perfection. We want the perfect lip, the perfect brow, the perfect patient experience. But I'm going to tell you something right now that might be hard to hear. You're going to make a mistake or two, and it's not a matter of if, it's a matter of when. So when I was in school, my professors always told me that half of what they were teaching me would be obsolete or wrong in 5 years. And the problem was they didn't know which half. This is the reality of medicine. It is a practicing science. It is not a perfect one. The most imperfect tool you have in your bag isn't your needle or your cannula. It is the admission of ignorance. In this field, if you think you know everything, you are dangerous. Your patients are not safe if you're not humble. We have all seen the expert who refuses to admit when something looks off or wrong. They keep injecting, they keep chasing a result. They fall into what I call the cash flow trap, trying to fix a clinical error with more product. We are going to stop that right now. We're going to learn how to practice with the net. You wouldn't drive a car without brakes or insurance, so why would you ever touch a patient's face without a plan for when things go wrong? When a complication happens, your brain is going to scream at you. You will feel shame. You will feel like an imposter. You might even feel like you shouldn't even be a provider anymore. I'm here to tell you to take a breath. A complication is not a reflection of your worth. It is a clinical event that requires a clinical response. We literally all are going to make a mistake in our career. It's not a question of if, but a question of when. So we are going to move away from the oops and move towards the protocols. We're going to look at how to look at a patient in the eye and be the most honest person they've ever met. Listen, this is a bountiful industry. It's growing, and there is plenty of room for you to succeed. But the providers who are the best and who last are the ones that can handle the bad days with the same grace as the good days. So let's get your head right and let's get started. Now that we have your head in the right place, let's talk about the actual conversation you're having with the patient. One of the biggest mistakes a new provider or a new nurse makes is trying to act like a magician. You want them to think that you're perfect. You want them to think that this is magic, but magic isn't medicine. When we as providers educate a patient on risk and side effects, most providers treat it like a legal chore. They rush through the consent form because they're afraid if they talk about bruising or bumps or asymmetry, that the patient's just going to walk out the door and not do the treatment. Listen to me. The exact opposite is true. If you don't tell them a lump can happen and then a lump happens, you're a bad injector. If you tell a lump might happen and then a lump happens, you're a responsible clinician who educated your patients on possible risk, right? We tell them about these risks so that when a complication occurs, it is a known rather than a secret failure. You are building a shield around your relationship. You are telling them, hey, I'm a professional. I know exactly what the road looks like, and I know where the potholes are. And if we hit one, we have some solutions. So this brings us to the most important part of your schedule, the 2-week follow-up. I never ever tell a patient that we are done on day one. I tell them that today is the first step in finding the recipe for their specific anatomy. Everyone's muscle's different. Everyone's fat's different. Everyone's bone structure's different. Their metabolism is different. Their pull is different. If I give you 20 units and you still have movement in 2 weeks, that isn't a mistake. That's data, right? We are learning how your body speaks. I tell them, hey, we're going to start conservative. We're going to see how your tissue responds. And in 14 days, we're going to look at the results together. If we need to make any corrections, we will. I tell patients that I'm creating a recipe for their specific self and their specific anatomy. And then I'm removing the stress of underdosing by doing so. I'm not fixing a mistake, I'm refining the result. I'm refining the recipe. That mentality keeps you safe, it keeps them happy, and it ensures you aren't overtreating and causing a heavy brow or a frozen face or filler migration, right? So now let's talk about your best friend in the clinic, your charting. If it isn't written down, it didn't happen. How many times have you heard that in medicine, right? And in the world of medicine, your documentation is your shield. When a patient has a concern, you document it. When you perform a correction, you document the why, the how, and what's next. You need to be specific. Don't just say treated lump. You need to say, identified a 2 mm firm module in the left nasolabial fold, performed massage, scheduled follow-up for 14 days. Good documentation, it isn't just for your medical director, it's for you as well. It allows you to look back 6 months from now and see exactly how that patient responded. It allows you to be a better provider. If you want to be a master of this craft, you have to be a master of the details. Be honest with your patients. Be patient with their anatomy and be diligent with your charting. That is how you build a practice that lasts. By now, you understand the recipe analogy. You understand that your documentation is your shield, but you have to deal with the hardest part of being a provider. We have to talk about the human being sitting in your chair who isn't happy with their result. Maybe they have a Spock brow. Maybe their lips have a ledge. Maybe they just don't feel like themselves anymore. Before we get into the mechanics of this conversation, I want to point out that we have an entire dedicated course specifically on the patient consultation. If you want the full deep dive on how to build that initial high trust relationship from the very first minute that they walk in, go watch that course. It is the foundation for everything we are talking about here. But when a mistake happens, I want you to remember the restaurant story. So I talk about this all the time because it is the secret to business. If you go to a high-end steakhouse and they bring you a cold overcooked steak, how that manager handles it determines if you ever come back. If they hide in the kitchen and the waiter avoids your table, you're gone, right? You'll tell 10 friends never to eat there and how horrible that experience was. But if the manager walks out, looks at you in the eye and says, man, I'm really sorry that that steak was not up to our standard. So I'll tell you what I'm going to do. I'm going to have the chef fire up a fresh one personally. And while you wait, dessert is on me. So what happens? You become a customer for life. Why? Because the manager was honest. They took ownership of the mistake and they made it right. In your clinic, you are that manager. So when a patient points out an asymmetry or a lump, don't get defensive. Do not try to gaslight them by saying it looks fine. That's the fastest way to lose a patient. Instead, use the script of radical transparency. Look them in the eye and say, you know what? You're right. That isn't the perfect result, what we were aiming for. Here's why I think your anatomy responded this way, and here's exactly how we're going to fix it today. When you admit a mistake or a complication, and that really wasn't a mistake, it was more of a complication. If you admit that before they ever point it out, you're not showing weakness, you're showing mastery. You're showing them that you are the expert who's going to walk them through any complication to a successful outcome. We call this practicing with a net. Your honesty is the net. If we have to dissolve filler, tell them about the prune effect. Tell them, hey, for the next 48 hours, you might look a little different. It's part of the process. Trust me, we're going to get you back to a clean slate so we can do this the right way. When you handle a complication with this level of transparency, you don't just fix a face, you build a bond that no amount of marketing can buy. All right, so there's mistakes and there's complications. And sometimes as providers, we look at all complications as a mistake that we made. That's not the reality of it. Complications are known side effects that you talk about your patients well before you ever do the treatment. So like if you're doing talks, you're going to talk to them that they might get a little bit of headache, they might get a little bit of bruising, they might get a little swelling. Those are not mistakes, that's a complication, right? Mistakes are, hey, I put the wrong tox in the wrong place. Maybe I injected too low and dropped an eyebrow. That's a mistake. And when you make a mistake, you need to own it with your patient. Hey, you know what? That was an injection technique on me. I don't want that experience to keep you from doing this therapy in the future. And while that was a mistake on me, here's the good thing. I never have to make that mistake again. We now know that we have to inject higher. So your next treatment, we can inject a little bit higher and we can avoid that mistake again. Patients understand mistakes. They don't understand that when you hide them. Nurses and nurse practitioners get sued at a level about 80% less than providers. The average physician in America gets sued 25% of the time. They have a 25% chance of getting sued at some point in their life. The average nurse practitioner, 4%. Why? Nurses tend to talk it out more. They tend to own it. They tend to, not, try to hide things. They're more trusted, and that trust comes with benefits as well. Now, let's shift gears a little bit. You're going to have, we've been talking mostly about normal people that come in and you have a little mistake. They're fine to deal with. But occasionally, in about 1 out of every 100 patients, you're going to come in, they're going to have unrealistic expectations on you and your skill level. They are looking for perfection, right? And typically, if you do a good consult, you can pick up on this very early. that they are a perfectionist. When they start pointing out little tiny slight imperfections on their face, like, hey, I've noticed that my left cheek's just like 1 millimeter, less protrusion than my right cheek. Or, hey, I'm looking at my lips and I noticed that my top cupid bow on the right is a half a millimeter lower than the cupid bow on the left. I want you to fix that. Or they just start pointing out all these little tiny things, and they've had lots of work done and they've been to lots of different providers. Your red flag warning should come up, because what this patient is telling you without telling you is they're going to be very, very, very difficult to work with. Trust me, I have dealt with these patients. In fact, as I'm talking to you, I'm thinking of all the ones I've dealt with in the past, okay, and how I've treated them, and eventually we have to go our separate ways. So if you have those patients come in, you need to say, listen, you're asking for perfection that I cannot give you. I can improve what you have, but I will never get rid of all these asymmetries, because the face by definition is asymmetrical. There's not a symmetrical face on planet Earth. And while I understand that you're looking at the magnifying mirror and you're seeing all these imperfections, you're the only one on earth that's noticing that. Now, patients don't like to hear that, but it allows you a way of giving yourself a professional out. They'll either not do the treatment, or if they do the treatment and come back 2 weeks later and they're like, hey, we didn't quite balance it out, you can say, yeah, I told you I can't do that. I told you I can't be a perfectionist. While I think overall it looks great, you know what? For you, it didn't hit the mark. So what do you want to do? Do you want me to dissolve it all out? Right? It gives you a way out. Don't get caught in the cycle of perpetual touch-ups. It happens all the time. Somebody will come in for some under eye filler. It looks great when they leave. They lay on their face. The next day it's moved, and then they're coming back and you're touching it up and you're adding and you're adding and you're adding and you're adding. And before you know it, you've lost hundreds of dollars in this patient. Okay. Keep your eyes out for these patients. They will tell you they're one of these patients well before you ever do a treatment. And if you can catch it early, your life's going to be a lot easier. Let's look at the Spock brow. This is the lateral frontalis overactivity that we'll often see after a neuromodulator treatment. The most common call you're going to get on day 10 after a neuromodulator treatment is the Spock brow. Oftentimes when we treat the frontalis muscle, we won't treat lateral enough. Remember, in 98% of patients, the frontalis muscle stops at the temporal fusion line, okay? Where these two bones meet together. It's that bony ridge that you can feel on most patients. That's where the muscle stops. And sometimes we don't inject to the temporal fusion line enough, and we're a little bit too medial to that line. And if we do, we'll leave a little band of muscle fibers that are still active on the corner of or on the edge of the forehead. And when they express, this is all frozen, but that lateral projection of the frontalis muscle still works, and it pulls up the corners of the eyes. And while some patients like it, most do not. Now, 98% of the time, the frontalis muscle ends at the temporal fusion line. I have found that, and I see this in practice, and this is in the literature, 2% of patients, that frontalis muscle actually goes over the temporal fusion line. And it's not noticeable until you actually treat them with tox, because you might treat all the way to the temporal fusion line, but if they have 3 or 4 millimeters lateral to the temporal fusion line, that little band is going to be lifting up the corners of the eyebrow, right? And then and only then do you inject a couple of units over the temporal fusion line, and you make a note, hey, make sure to put 2 units over the temporal fusion line, right? Because they have that little band of muscle over the temporal fusion line. So that's another thing that might cause a Spock brow. So if a patient ever comes in and they have an ill effect, you always ask yourself the following questions. What's the problem? Spock eye. What muscle is causing the problem? The frontalis muscle. If I turn that muscle off, will the problem be fixed? And if you ask those 3 questions, you'll always know where to put your injection. So let's go through that exercise. What muscle is causing the problem? Frontalis muscle, okay? If I turn the frontalis muscle off, will it fix the problem? Yes, because it will relax the muscle and the eyebrow is going to come down. Okay, let's change it up again. Let's say you made the wrong call. Let's say you say, okay, what's causing the problem? And you say the orbicularis oculi, all right? If I turn off the orbicularis oculi, will that fix the problem? Well, and then you go through the critical thinking. Well, the orbicularis oculi on the lateral projection of the brow is a depressor. If I turn off a depressor, the levitator becomes more dominant. Will that make the eyebrow go up or down? Well, the eyebrow is going to go up. So by asking those three questions, you just caught your own mistake. It wasn't the orbicularis oculi causing the problem. It was the frontalis muscle causing the problem. And we need to inject the frontalis muscle to fix the problem. So hopefully that makes sense. Now let's switch it. The second most common thing we see in neuromodulator injection is not an elevated eyebrow, it's actually a depressed eyebrow, or we call that ptosis, right? So, patient comes in, they feel heavy. They feel the brows heavy. You have them animate, you still see a lot of movement. You don't see any movement in the frontalis muscle, but you see a lot of movement in the glabella. And you might also see some movement over here on the lateral projection of the orbicularis oculi as well. So then we're going to go through that scenario again. All right, what's the problem? Heavy brow. What muscle is causing the problem? Let's say you say the frontalis muscle. All right, I'm going to say the frontalis muscle is causing the problem. If I put more medicine in the frontalis muscle, will I fix the problem? Okay, well, the frontalis muscle is an elevator of the brow. If I turn off the elevator more, will the brow become more elevated? Because that's what I'm trying to get. And the answer is no, it's not the frontalis that's causing the problem. So we back up. What's the problem? Heavy brow. What muscles are causing the problem? The glabella, right? Or maybe the orbicularis oculi on the lateral projection. If I turn those muscles off, will the brow go up? Well, those muscles are all depressors. If I turn the depressors up, the levitators become more dominant. And then, yes, the brow will rise. So the answer to your question is we put more medicine into the brow. So that's the way you have to think with neuromodulators. That's how you're going to get over the yin and the yang. Because remember, in the face, all muscles are either elevators or depressors. We have a major depressor here called the platysma muscle. It's pulling down the face. We have depressors here called the depressor angularis oris. It's pulling down the corners of the mouth. We have the depressor of the glabella. We have the depressor of the orbicularis oculi on the sides of the eyes. All of those are pulling down. And then we have levitators. We have levitator labii. We have frontalis muscle that's a levitator, right? So how that yin and yang works is how you're going to critically think through all of these scenarios. Let's talk about eyelid ptosis. Now, eyelid ptosis is not a very common thing that I see in practice. In fact, I can't think of an instance where I actually caused eyelid ptosis. Honestly, eyelid ptosis is a clinical error of diffusion. So when we treat the glabella, or for these 11 lines, if the toxin migrates past the orbital septum and hits the levator superioris, right here, the muscle, and that, remember, that's the muscle that actually lifts the eyelid. The eye itself was going to droop, not the brow, the eyelid. This usually happens because the injection was too deep or too close to that supraorbital notch. All right. So what's the correction? And this is where you have to really use your medical expertise. You could prescribe drugs that are alpha adrenergic drops like Upneek to stimulate the Mueller's muscle and temporarily lift that lid while the toxin wears off. Other than that, it's a watch and wait type of situation. And then what you're going to do is you're going to chart on this patient. Hey, make sure to inject superior to the brow and not get close to that orbital rim so we don't hit the wrong muscles, right? Because you don't want to make that mistake again. And then let the patient know, hey, you know what? The medication drifted. It hit this muscle. That was my intent. Now we know next time we're going to go a little bit higher and we'll never have this happen again. So let's talk about the frozen face. Sometimes I'll have patients come in, it's not often, but I'll have patients come in and they go, listen, I love a frozen face. I don't want to be able to move anything. And that's a really hard thing to hit. It takes a lot of medication. You have to physically, manually spread out these toxins all over the face. And you have to kind of go lower than you normally want to do to avoid ptosis, because you got to be able to freeze the lateral movement of their brows as well. So it's a really difficult thing to do. And I'll often encourage them to rethink that situation. And I'll say, hey, listen, you want a little bit of movement. Like, you're a beautiful woman. When you laugh, I want you to be expressive. And then I'll actually do that that look for them. I'm like, listen, I want you to be able to express your face a little bit. I don't want you to be like ha 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 and nothing moves. I go, that's not very becoming, right? I'd rather you go ha 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 and your eyebrows just come up a little bit and just show a little bit of interest in your face. And oftentimes that conversation will get them to kind of come over to my side of the fence. Some toxins like Xeomin are notorious for not freezing a face because they allow a little bit of movement. They're so precise that you can't turn off all of the muscles. So if somebody really wants a frozen face, you're going to have to get them into a product that spreads like Dysport. That's really the only one that I have found that really, really can give you a frozen face. Otherwise, with these precise toxins like Daxxify and Xeomin, it's likely not going to happen. I'll always tell patients, listen, tox is to prevent line formation. It's not a prevention of animation. Like I want a little bit of movement in your face. So if they want a frozen face, you can go for it. And then also tell them that if you're going for a frozen face, that hey, I'm going to have to inject pretty low on the frontalis muscle. I might cause ptosis, and if that happens, you're going to be pretty unhappy because you're going to be kind of stuck with that for a little bit. So, anyways, that's my suggestions on how to deal with the frozen face. When we start injecting the mid to lower face, we really start worrying about hitting the wrong muscles that, especially the muscles that affect the smile. All right. So let's start with lateral canthal lines. I mean, we inject around the eyes all the time. And remember, you want to be about one finger width away from the canthus of the eye, and that's the optimal area to hit the orbicularis oculi. It's also a very superficial muscle. You should be right underneath the skin. So anytime you inject that area, you should just barely put the needle tip in, lift it up, make sure your needle's just right under the skin, and just you're more bathing the orbicularis oculi than you are actually injecting the orbicularis oculi. And why do we bathe instead of inject? Because if you go too deep and you go too inferior into this malar region of the face, yeah, you might actually inject a muscle that you're not intending to, and that's the zygomaticus major and minor. And that muscle affects the way you smile. So it's what pulls the corner of the mouth up and lateral to the eyes. And if you hit that, what are you going to do? You're going to turn off the muscles that smile. And so if you hit one side and not the other, they might smile like this, and they can't lift up the corners of the mouth on the other side, right? And there's not a way to fix that. So if you hit it, it's just a time and wait situation. I mean, I guess the way you could fix it is to try to hit the muscle on the other side so they can't smile at all. But I've never had to do that. Now, I've never hit the zygomatic muscle injecting lateral canthal lines because I make sure I'm nice and close. But don't let these big, long wrinkles think that you have to inject way out here in the cyberspace, okay? The muscle near the eye is where you're targeting. Like look at my lines. I haven't had talks in a while. See how these lines go all the way out, right? That doesn't mean I inject all the way out here. That's not the muscles we're going after. We're going after the muscles right at the corners of the eye, right at the lateral canthus there. So to avoid that complication, superficial, one finger width away from the canthus of the eye, and you'll largely avoid that affecting that smile. The other muscle that there's two other muscles that we often can hit when doing some of these injections that will affect the smile as well. And one is the depressor labii inferioris and the risorius muscle. Okay, let's start with the risorius muscle. The risorius muscle connects the corner of the mouth laterally to the jawbone. It's what pulls the mouth to the side, like that. Okay. Now, sometimes we can hit that muscle if we're injecting the DAO. If we're too superior, we can hit that. But the most common time I've hit that muscle is when I'm injecting the masseter muscles. Okay, and I inject too high. Remember, you want to draw a line between the canthus, the oral commissure, and the ear, and stay below that line when you're injecting the masseter muscle. Because if you inject above that line and you inject too deep, you're going to hit that risorius muscle. Okay, so I want you to do an exercise. I want you to pull your corner of your mouth to the side, and I want you to feel that muscle, and you'll actually feel it kind of comes down at almost like a little bit of an angle coming down in there, right? And so you just want to avoid that muscle when you're injecting that masseter. Okay, and if you hit it, they can't smile, and there's no way to fix it. So avoidance is the way to not have that side effect. The most common unintentional muscle that we hit, that I see the most common in practice, is when we're injecting the DAO, the depressor angularis oris, and we accidentally hit the inferior labii. And when that happens, remember the DAO is what pulls down the corners of the mouth. It's what gives you that frown, right? That muscle right there. You can have a patient animate their face by having them stick their lip out and rolling it down. And if you do that, you will turn that muscle on. Sometimes you have to have them project their jaw forward as well, like that. So I want you to all to do that. I want you to make that lip and then feel that muscle tighten up right there, right? I got a really big band there. Must be a frowny Gus. Okay. So sometimes, as long as you can palpate it, you can hit it. It's usually about a half a centimeter lateral to the canthus and about 1 centimeter down is usually the landmark you're going for, like right in there. But you can't always trust on landmarks. If you're medial to that and you miss the DAO, you're going to hit the depressor labii inferioris, which is right here. It goes to the middle of the lip and it comes down at an angle like this. And what happens with that is when you smile, it pulls down the bottom lip. So if you hit that and you hit one side and not the other, what will happen is they'll smile, but this side won't come down. All right. There's no way to fix it. What I'll tell patients that come, they're like, hey, I smile crooked now, right? This is coming down, but this side's not. I'll say, listen, we hit the wrong muscle. I now know that I can't go where I went last time. So what I want you to do is I want you to smile without opening your mouth for the next 2 months. And if you do that, it keeps the lips closed and they won't have a crooked smile. So that's how we deal with that mistake of hitting the wrong muscle. And it is a mistake if you didn't put it in the right spot. So um, I always tell them, hey, next time I'll inject those muscles for free. I'm not going to do the whole case for free, but I'll inject those muscles for free since we had an unwanted result based off of my injection technique this time. And patients understand that. So I've hit that muscle a time or two in my career. I mean, not a lot, probably less than 10 times. When it happens, they don't like it, but I've never had a patient not come back because of it. So the other time you can hit the DLI is if you're injecting the metalis muscle. I was taught to inject the metalis muscle 2 and 2, and I found that if I did two injection points up top, that sometimes I hit that DLI on accident. So now what I do is I inject two spots low and one spot in the middle of the lip up high, and then I avoid hitting the DLI as a result. So I usually put about 6 to 8 units, like 2, 2, 2, or 3, 3, 2, something like that, into the mentalis muscle. And if I do in that technique a triangular injection pattern instead of a square injection pattern, I don't hit the DLI as much. So those are the muscles of the smile that if you inadvertently hit are going to cause some unwanted facial expression in patients. So you need to make sure you educate those patients that that could be a potential thing. And it always freaks them out a little bit. And so how I get over the freaking out a little bit when I talk about this stuff is I sit down and say, hey, I'm going to talk about the risks and complications with this. And then I go through it all. And by the end of it, they're like, oh my gosh, like, do I even want to do this treatment? Like you can see the wheels churning in their eyes. And then I always end it with this following. I'm like, oh, you know what? I forgot to talk to you about the biggest side effect. And their eyes kind of wide up. And I go, and that side effect is you're going to absolutely love this treatment. And then you watch the tension just go, oh, and then they laugh and then they do the treatment. So follow it up with something like that, or you can come up with something creative like, oh, I forgot about the most common side effect. Your husband's not going to be able to keep his lips off of you. You come up with something fun like that. And they're like, oh my gosh, well, I don't want that. And then you have a laugh and then they do the treatment. So come up with some sort of jovial thing at the end. And, it lets all that stress kind of wash away. So anyways, so that's how you can affect the smile with neuromodulators. Now go do the right thing. All right, let's talk about neuromodulator complications in the neck. And when we start injecting the muscles in the neck, we're primarily talking about injecting the platysma muscle. Remember, the platysma muscle is a superficial muscle right underneath the skin that goes all the way down to the clavicles, connects and comes up and wraps up around the bottom jaw, about a centimeter and a half up around the bottom jaw. And it is a major depressor of the lower face. It's also what gives you those neck bands. And I'll see if I can do some of these neck bands, right? And on really skinny, fit people, those neck bands become really, really apparent. Okay. Now, injecting these muscles is usually pretty straightforward. It's a superficial injection. You want to identify those muscles. And if you're injecting the bands, you're going to actually pinch the muscle when they animate and inject into that that pinch. Otherwise, it's the muscle tends to roll on the needle a little bit, and you tend to just inject between the skin and the muscle, which can still give some effect, but I'd rather put the needle in the muscle. Um, if you inject too deep in the platysma area, you can actually affect the way the muscles of swallowing, and patients could actually have a hard time swallowing, and uh, and that becomes a really bad problem. One of my colleagues, he works in the hospital over in Oregon. He had a patient come in who got um, the injections were too deep in the platysma, and they couldn't swallow, and they ended up having to put a feeding tube in until those neuromodulators wore off. Um, which was a pretty tragic thing because we have aspiration pneumonia and aspiration problems because we can't swallow. So you definitely don't want to go too deep with that. So always use a very tiny needle. 6 millimeter needles is adequate. You don't want to use an 8 millimeter needle in this case because you're going to probably inject too deep into the neck. The other complications that might arise from injecting the platysma muscles when we do a Nefertiti lift. Remember, Nefertiti lift focuses on the platysma muscle right at the jawline. And so typically you put 2 to 4 injections between the masseter muscles and the DAO. And I also will usually inject the DAO as well in a Nefertiti lift. So I'll usually do 2 units in the DAO, and then I'll do 3 injection points between the masseter muscle and the DAO. Now, if you inject too far medially and you're past the DAO, you might get some of that medication out of the platysma into the DLI. And if you hit the DLI, remember they can't smile. It's going to be like this, right? Because they can't pull down that corner of the mouth. So I always stop at the DA. I draw a line down the DAO, and that's where I inject until the gonial notch here in the jaw. Remember also that notch is where that um, facial artery goes through. And if you inject that notch, you're going to hit the facial artery and they're going to bruise. And I've actually done that once. I actually hit that facial artery on the notch. I think what I did was I actually pushed the facial artery out of the notch and I injected outside of the notch, but I had pushed that artery out because I was pinching the skin and I hit it and we had a pretty big bruise as a result. So we had to put pressure on that. I mean, it's a big artery and it was just pumping blood out. So you don't want to hit that facial artery. So avoiding those complications is just knowing your anatomy and knowing where to inject. Inject, that 6 units between the facial artery, between the masseter muscle. Remember that the edge, the medial aspect of the masseter muscle is where that artery is on the jawline. And so just move a couple millimeters medial to that and then inject towards the DAO. Don't go past the DAO. And that's how you're going to do your Nefertiti lift. All right. New studies have come out that say if you focus mostly on the jawline, you can do less in the neck for neck bands. So I'll do a Nefertiti lift and then I'll just put 1 unit at each neck band, in 3 or 4 spots, about an inch apart or a centimeter and a half apart. And the old technique was to do 2 units on each band all the way to the top. So new technique now is you inject the platysma muscle up high right at the jawline, and then you just follow those bands down with just 1 unit at each spot. And I've done that now in practice. It works remarkably well, and it actually uses a lot less tox as a result. So that's how you avoid complications in the platysma muscle with neuromodulator injections. All right, let's talk about complications with filler. And what we're going to talk about today is how to keep filler from migrating, and if it does migrate, how you're going to fix it. All right. Filler migration, honestly, is the #1 thing I worry about with any patient when we are injecting filler. And I educate all my patients that filler migration is the thing. And the reason I educate about it is that, when I got into the industry 10 some odd years ago, filler migration was rarely talked about because we didn't think filler really migrated. I mean, we knew it did, but we didn't think it was as big as a problem as we thought it was. And then what ended up happening in 2016, there was a provider down in California. He had a patient come in who had gotten under eye filler 10 plus years ago, and she was having vision changes. And he wondered, I wonder if some of this filler migrated out of the area. So he had a buddy who was a radiologist. He sent him over and did an MRI on this patient's face. And sure enough, that filler underneath the eye had migrated up above the orbital rim, down, and had ended up in the very back of the eyeball socket and was putting pressure on the eye. And anytime you change the shape of the eye, you're going to change the way the vision of the eye, and it gave this patient blurry vision. And so he had to send this patient to an optometrist or ophthalmologist, and they had to inject Hylenex back in there and dissolve out that filler, and her vision came back. But that was 12 years later. That filler had lasted for 12 years. So then he started doing MRI studies on all his patients, and he noticed that filler didn't tend to break down as much as it had moved into another area. And I've based off of those things, I started thinking about filler a little bit differently, especially when we start seeing these unwanted results related to filler migration. So let's start at the lips. The number one area that I have seen filler migrate is in the lips and the under eyes. So let's talk with the lips first. Why does filler tend to migrate out of the lips? Well, it tends to migrate out of the lips because the lips move a lot, right? Every time you're talking, the lips are moving, and anytime lip moves, it puts pressure on anything in there, and that pressure can move filler out of that area. And when filler moves out of that area, it doesn't look right. And so the golden sign of filler migration on the lips is that duckbill lip look, where the lips seem like they're pushed out a little bit, like they project forward too far. They look like Daffy Duck, and maybe it's more along the sides. And you can literally, because that filler has built up above the vermilion border around that orbicularis oris muscle, it tends to push the lips out more duckish like this. Okay. So anytime you see duck lips, I want you to think about filler migration. Not in the lip, it has migrated outside of the lip. And the way you fix it is with dissolving agent and just educate to the patient, hey, I suspect filler migration here. It doesn't look natural to me. Do you want to look more natural? Yeah. Now they're not going to pick up on this because they see themselves every day. You're going to notice it because you just walk through the door and you're like, that's not normal. But because it's been so gradual in their mind, they just think it's a normal look. Okay. So then we talk about dissolving and how it could take several treatments, and then we dissolve all of that filler out of the area. Okay. So how can you avoid filler migration in the lips? The first thing is to use an appropriate filler. There's a lot of fillers on the market that have FDA indication for the lips, and they all work. I mean, they're all hyaluronic acid-based filler. They all work. Filler that I like to use in the lips is filler that the body accepts better in the lips. And those are your round particle size fillers or small filler particle sizes. I'm thinking fillers like Readiness lips or Readiness Versa. These fillers have hyaluronic acid that comes in round particle size. Why round? When you put round in a movable area, it tends to flow a little bit better. It tends to integrate a little bit better. There's no rough edges to irritate the lips. You'll get less granuloma formations in these movable areas as well. And so choosing the right filler is really important in the lips. Another appropriate filler would be like RH8 or 3. While it has square particle size, I tend to see it integrate pretty well as well. Or a really fine filler like Redensity or Bellatero. These really fine fillers just fill in the gaps a little bit, and they tend to stay where you put them. All right. So choose the right filler. That's step number one. Step number two is putting the filler in the right place. When I was first injecting, and I might have even taught some nurses this, I would do my mini lip, I would do border work around the vermilion border, and I would go right at the vermilion border and I would put a layer of filler right at the vermilion border to make that border pop. But because I was right at the border, sometimes that filler would be superior to the vermilion border, and sometimes it would be inferior to the vermilion border in the lips, if I'm talking about the top lip. And you want the filler to be in the lip. So now when I do border work, I will actually put my needle in the vermilion, just inferior to the vermilion border. And I will follow the vermilion border in the lip rather than in the skin. And if you do that, that defining border tends to stay more defined. And you don't get that migration out of the vermilion border into the supra oral area of the lip. So right placement is important as well. So keep the filler in the lips. Don't inject in the skin. Okay. And then the third thing you can do to avoid migration is immediately after injecting the filler, work it into the tissue. Now, this is a new technique that I was taught probably about 4 years ago, and I've really adopted it, and it's been miraculous on filler migration. So after I put all my filler where I want it to go, I'll take my fingernail, I'll put some lubricant on it, and with pressure, I will just rub that area of the lip. Always lateral to medial. I don't want to push filler laterally, I want to push it medially. So I'll grab the lips and I'll push the lips together like this, and I'll work that in with my fingernail, and just like if this is the lip, I'll just lightly rub that with my fingernail. Obviously, it's lubricated. Obviously, I have a glove on, and I'll just work that into the tissue. And by working it in the tissue, it tends to spread out that filler into more fine little particles, and it gets integrated in the tissue a little bit better. And since I've been doing that, I see a lot less filler migration. So those are some techniques you can do to avoid that complication of filler migration in the lips. Now let's shift gears and talk about filler migration in the second most common area, which is underneath the eyes. All right. Um, Underneath the eye, filler is not something I like to do much in my practice because of migration. Nearly 100% of the time, filler will migrate out of that area. And the reason why is there is a ligament that goes from the corner of the eye down through here that connects the skin to the bone. And that ligament is really, really um, a problem when it comes to filler migration, because when you put filler underneath the eye, sometimes you're medial to that ligament, sometimes you're lateral to that ligament. And that ligament is going to push filler one way or the other, depending on which side of the ligament you put it on. So that ligament is also the defining line of a lot of the problems underneath when we do under eye filler. And so I'll put filler in and the patient will leave looking amazing and then come back 2 weeks later and say, hey, I looked amazing when I left, but now I've got, I've got this little pudge here. And then you go in and you put a little bit more filler, right? And then 2 weeks later they come back, they're like, hey, I got this little pudge. The line between filling to effect and overfilling in this area is very, very small. And you have to treat to effect without over treating. And as soon as you over treat, filler migration happens. So I find underneath the eye, it's much more advantageous to inject the cheekbones and put filler right on the cheek. And if you put filler right on the cheek, it tends to support the under eye area a lot better than putting filler directly in the under eye. So the first way you could avoid filler migration underneath the eye is just don't do under eye filler. I haven't done under eye filler in years. I usually, if people have they've lost volume here, I'll support the cheekbones and I'll get to a good result that they're happy with. I once had a patient come in, a brand new patient. She came in, she hated her under eyes, and she said, "Yeah, I've got these little pouches over here too. I hate." Way over here. I'm like, "Oh, have you ever done filler over there?" She's like, "No, I've done lots of under eye filler, but I've never done it over here." And so I start palpating that area and I'm like, gosh, it kind of feels like there's filler there. And I told her, I go, I think you got a lot of filler over there. She's like, I've never put filler over there. Well, I go, well, I think it migrated. I go, let me do a dissolving treatment in that area. And these areas were pretty pronounced. Like they did not look good. And so I took some Hylenex and I mixed it up and I injected that area and immediately it went away. That Hylenex just broke it all down. And I was her best friend because she had those things for 5, 6, 7 years. It had been that long since her last under eye filler. It had migrated all the way over to here. And she had these little balls of filler. And they were a little Tyndalled as well, which is another reason I was thinking that it was filler. You get that Tyndall effect, that discoloring of that area. And we dissolved it out. So under eye filler tends to move. And another reason why it tends to move is you're using very fine filler. This is the thinnest skin in your body. And so you have to use a really fine filler to make that look good. And fine fillers tend to move more than chunky fillers. And that takes us to our next place that filler migration happens, and that's in the cheekbones. In the cheekbones, I do not like to use fine fillers. I do not like to use round particle size fillers because they move, they're round, they flow, right? I don't want them on cheekbones. You wouldn't build a house with round stones as the foundation. You'd use blocks, right? You'd use cinder blocks to build the foundation of your house. Well, you need cinder blocks on your cheekbones. So you need to use a very high G prime filler that has square particle size. I'm thinking RHA4, Radiesse. I'm thinking fillers like Juvederm line of fillers like Voluma or Restylane Lift. These are all fillers that are made to be put on bone and they stay on bone. And migration in the cheekbones is all about selecting the right appropriate filler. And also educating your patient that, hey, I just put filler on your cheekbones. This is a liquid. And if you do this, you're going to squish it out of there. If you sleep on the side of your face for a couple weeks, it's going to squish it out of there. So you tell patients, get an airline pillow, put an airline pillow around your neck so you keep your pressure off your face at night, or if you can, sleep on your back for 2 weeks until the body biofilms it, and then you can go live about your life. So education on the patient, lip migration, if they do extraordinary movement with their lips, they're going to put pressure on that filler to squeeze it out of the lips as well. So I tell people don't sing in the choir, don't do oral sex, avoid doing these really big movements for 2 weeks of the lips. Same thing with sleeping at night. You don't want to put pressure on those faces. So that's how we're going to avoid migration in those areas. So you just injected filler on a patient. 2 weeks go by, your patient comes back and says, "Hey, I still have this bruise that isn't going away." And you look at the area you just injected and you realize this isn't a bruise, this is a Tyndall effect. Tyndall effect is when the filler you place is very, very, very superficial. The light is shining through the skin. It's reflecting back off of the filler, and it looks like a bruise. It looks like a gray area, an opaque area, a light bruise, something like that. And Tyndalling happens if you put the filler too superficial. Now, remember, filler is meant for two planes of the body. It's meant to support subcutaneous tissue. So we want it right under the skin, which is the subcutaneous plane, or right on the bone, which is the subcutaneous plane, right? You got bone, subcutaneous tissue, muscle, arteries, nerves, subcutaneous tissue, skin. So we want it under the skin, that subdermal layer is where we'd like to do it. We don't want it in the skin. When you put filler in the skin, it Tyndalls. Okay. If you put it under the skin, it tends to not Tyndall, except for right underneath the eyes. Remember, underneath the eyes is the thinnest skin in the body. If you do under eye filler, sometimes you can get that Tyndall effect, even though you were deeper than subdermal area. Okay. Other areas I see Tyndalling effect most notoriously is in the lips. If you are right in that plane of the vermilion and your needle's just kind of going through the vermilion, you put filler, it's going to Tyndall, and it's going to look like a bruise that is persistent. All right. So I see a lot of Tyndalling, not a lot. I see Tyndalling happening in the lip, and I do see Tyndalling happen underneath the eyes. Those are the two most common places I see it. But anywhere that you put it too superficial in the skin, you can get Tyndalling. Another area you might see some Tyndalling is if you're feeling perioral lines. That's a really thin area to use. The way you get around Tyndalling in the perioral area is to use an appropriate filler. You want to use a fine filler, like a Redensity or a Bellotero. And if you use a fine filler, it tends to settle into the cracks a little bit better, and we don't get much Tyndalling. The other way you can avoid Tyndalling in that area is microdosing filler. Like, don't put big balls of filler in the perioral area. Little tiny 0.01 injections, and then that fine filler just settles in the area. Now, the only way you could fix filler is one of two ways. One, you could try rubbing it in. So get a gloved hand on, put some lubricant on, and just rub that area and see if you can put that filler out of the skin down deep. I've had some success with that, but realistically, what we end up doing is we just dissolve that filler out of there. You get a needle, put a little bit of Hylenex in it. It doesn't have to be much. Maybe 0.1 milliliters of Hylenex mixed with, another 0.1 milliliters of saline, maybe a little lidocaine in there, and then just inject that little spot with a little bit of Hylenex. You don't want to dissolve all of that filler out of the area, just the spot that's a problem. And obviously, if you're doing Hylenex, you always do a test first, make sure they're not allergic to it. 1 in 2,000 people are allergic to Hylenex, which doesn't sound like a lot, but when you take 300 million Americans and you have 1 out of 2,000, you're talking about millions of people that have a potential, well, maybe not millions, but yeah, millions of people that might have an allergy to Hylenex. So always test it, do a little blood test on their forearm before you do it. And that's how you address Tyndalling in your practice. Best way to address it, don't ever let it happen. The complication you're going to see a whole lot when you're doing any type of filler are nodules or lumps. Nodules or lumps happen when a ball of filler gets encapsulated by the body and a biofilm is placed around it. And if you don't address it soon, that nodule or lump can kind of form almost like a collagen ball that takes years to break down. So um, bumps and lumps happen. You always should be telling your patients about bumps or lumps. Now, there's certain fillers you can choose that will have lower chances of bumps or lumps. I'm thinking like Versa and Lips are round particle size. They tend to integrate with tissue a little bit better. with balls or lumps. And most balls or lumps you're going to find that patients complain about are going to be in their either underneath their eyes or in their lips is what patients really get bothered by balls or lumps. So with hyaluronic acid based balls or lumps, the best way to fix it is at your 2-week follow-up. If you feel a bump or lump, you take a gloved hand and you squeeze the hell out of it. And it hurts the patient a little bit. You say, hey, I'm going to squeeze on this bump or lump. I'm going to try to pop it. And it's going to be a little bit tender because that bump or lump is going to push it up against the nerve, especially in the lips. And so you just grab it, and you just squeeze it, and you'll actually feel it pop sometimes. And if you pop it, you don't have to worry about it anymore. If you can't pop it, then I would get some a hot pack, and I would rub, and I would just massage and see if we can break that down with physical pressure. That's the best way to do it. The second best way to break down a bump or a lump without dissolving out the bump or lump is to get a really tiny needle and try to poke the needle into the bump or lump and try to break it down with a needle. Like I will do this often if I get radius nodules. Radius tends to have a more propensity in its direct form and non-diluted form to form bumps or lumps. And I had a patient one time, we did some jawline filler on her, and she got a little bump right here on the jawline. It didn't get placed right on the bone, or if it did, it came off the bone and just kind of set up in that subcutaneous plane. And she had this bump or lump. And what we did is we just got some saline and we put it on a syringe, and I took a 21 gauge needle and I pinched that bump or lump. And it was a pretty good sized bump. It was about a 2 millimeter bump. And I just pinched that in my hand, and I just broke it down with that needle. And I just pinched that, and I just felt the needle in between my fingertips. Obviously, we're being very careful not to come back up through the skin and poke yourself. And I just broke that down and just kind of irrigated that whole bump or lump out. And I did that twice. And I had to do it twice. After the first time, I broke it down like 75%. There was still a little bit left. I did it a second time, and boom, that bump or lump went away. Is that filler still in there? Yeah, but I diluted it down and I moved it out of the area and just kind of flushed it away. So you can definitely flush radius out of the area by diluting it down and getting those little calcium particles spread out. So that's a really good way of doing it as well. The third and final way of getting rid of a bump is to use a little bit of Hylenex. Pinch that bump, get a little 0.1 milliliters of Hylenex mixed with a little bit of lidocaine and a bacteriostatic saline, and then just put that needle in. And as soon as you feel that needle go in that bump, just put a little squish of Hylenex in there, and you can actually feel that bump and lump break down. So that's another way of getting rid of that complication. So bumps and lumps happen. They don't happen often, but I tend to see it 2 or 3 times a year in my practice. Somebody will come in with a bump and lump. We'll have to address it. And the more filler you do, the more it's likely to happen to you. Again, as long as you educate with your patients about it, it's a known complication. This is not a mistake that you made. So talk to your patients about it, give them informed consent. And then when they come back for that 2-week follow-up and they got a bump or lump, you know how to address it. So anyways, that's how I deal with bumps or lumps. Now you go seize the day. All right, probably the biggest complication we worry about when we're injecting filler is the notorious vascular occlusion. We're terrified of this because it is a medical emergency. You can have tissue necrosis, blindness, you can lose a lip, you can lose a tip of a nose. All of this can happen for improper placement into an artery or a vein of your hyaluronic acid-based filler or your non-hyaluronic acid-based filler like a radius. So the way you deal with a vascular occlusion is you come prepared to every filler injection. And you need to assume that that filler injection you're going to do today is going to result in a vascular occlusion. And if you have that mentality, you will always be prepared for it. Now, I'm not going to dive into how to reverse a vascular occlusion right now because I have filmed an entire course on how to reverse a vascular occlusion on a patient. So I want you to refer to that course to see how. But the moral of the story today is be prepared. Have the protocol on how to deal with the vascular occlusion ready. Have everything on that protocol. Make sure all the medications on that protocol aren't expired in your emergency kit. If they are, get them replaced. Okay. You have to have adequate supplies. You have to be ready for it. If you're doing a mobile practice and you're doing filler in somebody's house, you better have that Hylenex with you in a refrigerated container because you might need it that day. So just be prepared. If you're prepared, you'll know what to do, and you're going to be scared. But if you have a written list, you can just go down the list. Hey, notify the medical director. Do this, do this, do this, do this, do this, do this, and boom, you're taking care of it. Remember, a vascular occlusion is not malpractice. What's malpractice is not being able to reverse a vascular occlusion if you were to do it. So as long as you're prepared, you're doing the job right, you'll be ready to deal with it. Now go watch the vascular occlusion course that I filmed, and you'll be able to deal with that complication. So in closing, listen, this is your future in aesthetics. I know we've covered a lot of scary stuff in this course, but I want you to remember why we're here. You're a nurse, you're a provider, you're an entrepreneur. You are in a bountiful industry that is literally changing people's lives. The fear you feel right now, that's just your professional conscious making sure you're ready. Take these protocols, study these musculoskeletal maps, keep your eraser close, and honestly, even closer. If you do that, you are miles ahead of others in your field, and your clients will be understanding if and when you make a mistake. You've got the tools. Now go out there, take care of your patients, seize the day, and make this business your own.